things that will revise for 2-3 minutes what we learned in the last class, and then we'll go on to the fresh class. So we have seen towards the end of the last class that there is a difference between the clinical presentation of a lesion in the upper motor neuron and the lower motor neuron, right? A very classical difference. Tone of the muscle is more in upper motor neuron lesion and tone of the muscle is less in lower motor neuron lesion. You have seen two words, spastic and flaccid. If you come below, the next one, very striking difference is muscle atrophy, which is a very classical and outstanding feature of lower motor neuron lesion. The next important point is the deep tendon reflexes. Deep tendon reflexes, examples of them are knee jerk, ankle jerk, bicep jerk, tricep jerk, all of this. So whichever reflexes we strike the tendon of muscles, these are deep tendon jerks. And physiologically, I mean the circuit wise, they are stretch reflexes. So there is an exaggeration of the deep tendon reflexes in UMN lesion, right? But not so in the LMN lesion. This is one important point of difference. And Babinski sign. The Babinski sign was the abnormal plantar response. Normal plantar response mein what we find is there is a plantar flexion of the toes, curling of the toes, crowding together and plantar flexion. In an abnormal or a Babinski sign, there is a fanning out of the smaller toes and dorsiflexion of the great toe. And if it is a stronger stimulus, there is even dorsiflexion of the ankle. That also can be there. So this is an abnormal thing. We have discussed the reasons. I'm not going to do this again. Now today we'll talk about the various levels of control of muscle tone, differentiating the various forms of abnormal muscle tone and postural reflexes, right? So these things I am reinforcing in each class, right? Because these are important concepts. Tone is defined as the resistance of a muscle to stretch, passive stretch, and tone is mediated by the gamma motor neurons, the stretch reflex. So control of tone is one at the level of the spinal cord, the reflex arc itself. The second, it has a different descending tracts which influence tone. So when I say passive stretch, so if you flex the elbow joint, right, which muscle is stretched? Biceps or triceps? When you flex the elbow joint, which muscle is stretched? Triceps. So here important point, conceptual point you need to remember when you go in the labs for testing tone. Clinically, whenever you examine tone, you remember you have to do passive movements in such a way that the muscle that you are going to test, that should be stretched, right? If you want to test the tone of biceps, for example, what will you do? You have to stretch biceps. Biceps mein, this is the normal configuration. Elbow joint cannot be hyperextended. You cannot go beyond this. How will you stretch? If you want to examine the tone, how will you stretch? So you start from a flexed position. Flexed elbow say whenever you extend. So now here it was smaller in length. As you extend it, it is getting stretched. So those joints where hyperextension is not possible, normally you cannot go beyond this. So you have to use this trick. You start from a flexed position and go to the neutral or normal position. The tone where you remember always you stretch the muscle and feel the resistance that the muscle is exerting as you stretch it. And this resistance is what you call as tone. There is no phrase or any objective way to tell this is normal and this is abnormal. Right? This is something you will learn with experience. When there is absence of tone, you will find that these movements happen without any resistance, abnormal situation. When there is increased resistance, this is a case of hypertonia. So normal tone is somewhere in between these two extremes. Now coming back to the tracks. This is a recapitulation of the previous class. I have just put things together. pontine reticulospinal tract is an excitatory influence on the tone, stretch reflex arc. So it increases muscle tone. Medullary reticulospinal tract inhibits muscle tone, right? Both these actions are happening through the stretch reflex arc or the gamma motor neurons. We also have vestibulospinal tract, which arises from the vestibular nuclei of the brainstem. Vestibulospinal tract का influence भी excitatory है, right? But this is independent of the gamma or the stretch reflex arc. Directly, alpha motor neurons are stimulated by the vestibulospinal tract, right? So does it have a role in a normal situation? No, normal health may it does not have much of a role because vestibular nuclei. We've talked about the pictures yesterday. Just go through that. Vestibular nuclei is normally inhibited by the Purkinje cell network of the cerebellum, right? So in any situation where this normal cerebellar inhibition is removed, like we talked of a situation yesterday, if cerebellar lobes are removed surgically or in an experimental setup in animals, or there is some form of ischemia, the blood supply to the cerebellar lobes are affected. So in all those situations, cerebellum का जो inhibitory influence है, that will be removed, and then vestibulospinal tract will keep on bombarding the alpha motor neurons in the spinal cord. This will lead to a state of hypertonia. Okay, now abnormalities of muscle tone, two extremes as I said is hypotonia and hypertonia. Hypotonia is also called as flaccidity, right? And hypertonia, there are two ways it manifests: spasticity and rigidity, right? In both of these two conditions, the muscle becomes hard in the sense that if you try to stretch the muscle, it will give you a lot of resistance in this process. So this is what happens in hypertonia. Flaccidity, as you see, is seen in lower motor neuron lesions. Now coming to spasticity. Now spasticity and rigidity both are forms of hypertonia. We use the word spasticity when this abnormal tone or hypertonia is because of hyperactivity of gamma motor neurons, right? So in UMN lesions or upper motor neuron lesions where pyramidal tracts are affected, we usually get hypertonia manifesting in the form of spasticity, right? उस context में this term or phrase is used, and you will see one more important thing here is clinically how do you know? You have got clinically before you go on the investigation, you get a patient where the tone is increased. So how do you know that this is whether it is spasticity or rigidity? Now when you start stretching a particular muscle, right? I'll again take the example of triceps. Whenever you're trying to stretch the triceps is resisting. So this is the resistance. So flexion, it will resist flexion. This is the resistance that we encounter as tone. Now in clasp knife pattern, right? Initially you will get a very high resistance. As you try to flex the elbow, starting where you will get a very high resistance, and suddenly there is a let go. So this pattern or picture is what resembles with a clasp knife, a pocket knife. You open it, initially it gives a form of resistance, difficult to open. Suddenly it opens like that. So this pattern is called as clasp knife pattern. ये picture अगर clinically रहा, use the word spasticity. What is the reason? So initial resistance is because of the hyperactive stretch reflex. Now when stretch reflex is hyperactive, उस affected muscle में there is a strong contraction. This is what the reflex does. Alpha motor neuron activate होंगे, extrafusal fibers will contract. The force of contraction will be more. Now if the force of contraction is more, Golgi tendon organs will get triggered and inverse stretch reflex or Golgi tendon reflex will come into picture. So inverse stretch reflex, what does it do? it causes a sudden relaxation of the particular muscle. You remember that particular example that we talked? If you take a weight, एक किताब ले लिया, you can hold it. Put one more, you can still hold it, but if you put one more, then suddenly it will let go. This happens because the body does not want the muscle to tear out of its attachments. The inverse stretch reflex. So here also, initial response, as I said, clasp knife pattern was because of the stretch, hyperactive stretch reflex. Sudden let go because of the inverse stretch reflex happening after that. This is clasp knife spasticity. Usually spasticity affects one group of muscles, right? Either the flexors or the extensors, but generally it is the anti-gravity muscles that you test clinically, right? Extensors may usually, but one group of muscles at a joint, either agonists or antagonists, right? Something like that. The other extreme or other form of hypertonia is rigidity, right? Now, rigidity is a term that is used in context of extrapyramidal lesions, right? Extrapyramidal traxmical lesion, or if you are dealing with a lesion of the basal ganglia, Parkinson's disease, some of you might have heard the name. So this hypertonia is because of alpha motor neuron activity, right? So this is the important difference. Spasticity हमने use किया gamma motor neuron में, and here we have used it alpha motor neuron. Rigidity can also be present during movement and also at rest. एक और difference ये है कि even if you are not movement में तो होगा ही, but even if the muscle or the particular group of muscle is at rest, then also there will be hypertonia. Rigidity can manifest in two forms: lead pipe rigidity and cogwheel rigidity. Lead pipe rigidity means throughout the course of the movement you feel the resistance, uniform resistance throughout the entire course of the movement. Spasticity में था कि initially there is a resistance, suddenly there is a let go. But here throughout the course of movement you come across resistance. Cogwheel rigidity, throughout the course of the movement you have interruptions, right? So there is hypertonia, but it is jerky. But पूरे range of motion में this jerkiness is there. So this is what you call as cogwheel pattern of rigidity. So what do you think is this particular type of rigidity, or is it spasticity? What do you think? Will you call it spasticity, lead pipe rigidity, or cogwheel rigidity? This is a cogwheel rigidity, right? So I'm just pointing out the important differences again. Spasticity में resistance is felt initially, followed by sudden let go. Rigidity में throughout the course of the movement we come across resistance, hypertonia. If it is smooth throughout the course of the resistance, it is lead pipe. If it is interrupted throughout the range of motion, this is cogwheel type of rigidity. So having known the motor patterns now, so we'll discuss one particular clinical scenario, right? So this has both sensory as well as motor features. So you find a person or patient brought to the emergency after an accidental fall, right, from a tree, and he landed on his back, immediately experiencing severe pain in the mid-thoracic region, right? Severe pain, why? This could be because of a fracture now, right? If you fall on your back, you might as well get a fracture. This will cause a pain. When you do examination, you find that vitals are within normal limits, but he is unable to move his left leg, right? He also reports that he is not able to feel the position of the left leg. So दोनों चीज़ें affected है. Sensory affliction is there, position sense is affected. Motor is also there, is not able to move his left leg now. Further examination, what does it reveal? Left side में there is a loss of all the sensations. So use the word anesthesia. Analgesia, remember, is a term we use for loss of pain or absence of pain. But when he use the word anesthesia, that means all sensations are not felt, absence of all sensations. So loss of all sensations approximately 1 centimeter above the umbilicus, right? Loss of dorsal column sensations below the levels of anesthesia on the affected side. Exaggerated deep tendon reflexes with spastic paralysis of the left lower limb and a positive Babinski sign. Right side may you see there is a loss of pain and temperature sensation 2 centimeter below, right? And slight motor weakness, normal plantar response. So this type of scenario, the mixed presentation is there, sensory as well as motor. So most probably this scenario is not something to do with the cortex. Cortex में दोनों sensory और motor features आने के लिए the lesion has to be very broad, ताकि motor areas as well as sensory areas are affected. Only then this type of scenario will be there. Usually when you find this, it is usually something to do with the spinal cord. Because spinal cord में at all the segments you have a dorsal horn and a ventral horn, sensory and motor, right? तो segmental level पे जिस particular level पे injury है, it is suggestive of a fracture because from the history severe pain. So उस particular segment में the dorsal horn and ventral horn both are affected. So there will be loss of reflexes arising from that particular segment, loss of all sensations in that particular dermatome, right? And उस particular segment में whichever muscles are supplied, that there is again loss of all those motor functions. So segment पे wherever there is an injury, all functions are gone, right? Why? Because interruption of the dorsal and the ventral horn. The segment में रहा ही नहीं कुछ, there is no activity, no sensory, no motor activity. Now from here, what do you think is this level? Umbilicus में, what is the dermatomal supply of umbilicus? Which segment? Nerve roots. Thoracic, which number? T. You finished this, right? Yeah, umbilicus में it is at the level of T10. The nerve roots coming from T10. Here it is 1 centimeter above. So it is probably at the level of T9. Injury is at the T9. T9 के corresponding segment पे all functions are gone. Now why is that? Left side में, so T9 पे there is an affliction on one half, left half of the spinal cord. Dorsal column sensations are all affected. Why? क्योंकि dorsal columns जिस sides में receptor है, they are all traveling, they ascend in the same side. Crossing happens in the level of the medulla, right? So left side में जितने भी fine touch, proprioception, sense of position, 2-point discrimination, all of this, vibration sense, fibers carrying all of this is ascending from the lower limb, right, entering into the spinal cord, and it is ascending up, same side mid. So because these fibers are interrupted because of the injury, affected side में there is a loss of dorsal column sensations. इसी level पे we'll talk of the sensory. Pain pathway में crossing कहाँ पे? It is at the pain pathway में the crossing is at the level of the entry at the spinal cord, right? तो left side में अगर injury है, तो pain fibers, pain carrying fibers which were crossing at that particular segment, right? They are conveying the signals from the right half of the body. You understand this or not? Left side में spinal cord में lesion है, तो pain carrying fibers जो affect हो रहे हैं because of the spinal cord hemisection or injury, they are carrying sensations from the opposite half of the body, from the right lower part of the body. And what is the reason कि ये 2 centimeter नीचे है? Try to recall pain pathway में we talked about a small tract called a tract of Lizard. कि first order neurons once they enter the spinal cord, वो 1-2 segments ऊपर जाते हैं and then they cross in the anterior commissure, right? So that's why T9 पे जो pain fibers affect हुए हैं, they are actually carrying sensations from 2 segments below, right? That is the reason you have 2 centimeter below on the opposite side, pain and temperature fibers are affected. Coming to the motor features, affected side में, left side में deep tendon reflexes are exaggerated, spastic paralysis. So this is a upper motor neuron type of paralysis, right? तो corticospinal tract जो आ रहे थे ऊपर से, so crossing has happened at the for the corticospinal tract or the pyramidal tract, crossing has happened at the level of the medulla. जो fibers left side में आ रहे, that those fibers are affected. तो left side में there is a upper motor neuron type of paralysis below the level of the lesion, right? And 20% of the fibers which don't cross, left side में जो ऊपर से नीचे आ रहे हैं, you have 80% fibers of arising from the right side जो cross करके आए, so they will terminate on this side only. 20% of fibers, uncrossed fibers which come down, they cross at the level of the particular spinal segments and they form which part? The ventral corticospinal tract. Corticospinal tracts. 80% of the fibers, we call them as the lateral corticospinal tract. उनका क्रॉसिंग ऊपर हो चुका है. So whatever is coming down to the spinal cord, वो उसी साइड को सप्लाई करेंगे. Bulk of the fibers. So that's why left side में you see 1/5 of the power is left, right? This is a grading of the power. जो बचे कुछ 20% fibers से which do not cross at the medulla, they cross at the level of the spinal segments, forming the ventral corticospinal tract. तो जो T9 पे cross कर रहे हैं, they are crossing and supplying the right side of the body, the motor supply of the right side of the body, but the contribution is less, 20% only. So that's why you have slight motor weakness of the right side. So this type of pattern is called as Brown-Séquard Syndrome, hemisection of the spinal cord, right? So if you want to sum up now, what you find here, see this side it's affected, that is the picture. Ipsilateral side, जिस side में lesion है, below, let's talk of the lesions below. So below the level of lesion, same side में there is a loss of dorsal column sensations, right? Same side में there is upper motor neuron lesion type of paralysis, spastic paralysis. Opposite side में there is a loss of pain and temperature sensation, usually 1 to 2 segments below, and slight motor weakness because the 20% fibers ventral corticospinal tract. At the level of the lesion, there is no activity, no sensory and no motor activity because spinal cord itself is spinal neurons and the reflex are affected. One more additional feature that is not there in this situation, if these lesions happen at the level of the thoracic and lumbar segments, one more thing that can happen is autonomic disturbance. Why? Remember thoracic and lumbar segments में dorsal and ventral के साथ you also have one intermediolateral horn, right? So intermediolateral horn gives rise to the sympathetic preganglionic fiber. So that particular horn will also be affected. So sympathetic supply उस particular segments जो arise हो रहे हैं and the organs that they are supplying, so there will be a fluctuation in the blood supply, right? And if it is a large lesion, it can also lead to some fluctuations in the blood pressure, right? These are additional features. So you have sensory feature, motor feature, and if it is a lesion in the thoracic and lumbar segments, you might have autonomic features also. Moving on to the next topic, regulation of posture. Now, regulation of posture, it is by the conscious systems that we described. Posture आप voluntarily कर सकते हो control using your corticospinal tract. You can stand erect, right? You can always do this. Cerebral cortex say you can think, yeah, I'll stand like this. This will be my posture, and you can always do it. Apart from this, you have in the body at various levels some postural reflexes, so that in any situation where cortex takes some time to come into action, you have a lot of protective reflexes which maintains posture. So you have, I'll go to the directly, you will see the centers also. Anti-gravity muscles, the first one, right? So anti-gravity muscles, you can see integrating center, right? Tone of the anti-gravity muscle. This is the first one at the level of the spinal cord. Positive supporting reaction, again at the level of the spinal cord. Crossed extensor reflexes, spinal cord भी integrate हो रहा है. Labyrinthine reflexes and neck reflexes, this is integrated at the level of medulla. Writing reflex at the level of the midbrain, and hopping and placing reactions at the level of cerebral cortex. So you see, motor hierarchy में नीचे से लेकर ऊपर तक you have at various levels a lot of reflexes, a lot of posture maintaining mechanisms which are there, and this can happen even without involving the conscious thought of adhering to a certain posture, right? So we'll discuss about them briefly one by one. So anti-gravity muscle tone, the first mechanism that is there, which maintains erect posture. So all those muscles which help you to support the weight on the weight-bearing joints. So at the neck you have erector capitis, erector spinae, then you have the gluteal group of muscles at the hip, and the quadriceps at the knee joint. And usually, right, these muscles have a higher tone compared to the other muscles of the body. So the body is built like that anti-gravity muscles में जो resting tone है, it is slightly higher than the other muscles of the body. And decerebrate posturing जो हमने last class में देखा था, you remember there was a characteristic जो extensor predominance है in decerebrate posturing. The upper limbs were extended, lower limbs are also extended. Why? Why not the flexes? Because naturally in the body there is a predominance of the extensors, right? Tone of the extensor is slightly more than the other group of muscles. Next one is the positive supporting reaction. Now this is important, especially for the ankle joint. How is the ankle joint different from the other weight-bearing joints? Say from the knee joint, how is it different? Knee joint में you have a neutral position, right? You cannot go to the opposite, like hyperextension is not possible. There's only one. You can either flex or extend it back to the neutral or normal position, right? You cannot go beyond this. Flex and you can extend back to the normal position. Ankle joint में you can move both ways. This is the difference. You can plantar flex, you can dorsiflex. So there is one neutral position, one dorsiflex position and one plantar flex position. So when you talk of this postural reflex as such, so main thing that we learn with practice is how the ankle joint can be steadied at the right position. This is called as a positive supporting reaction. So you see, if the tibialis anterior muscle contracts, so what will happen? There is dorsiflexion. So there is a tendency of falling forward. If gastrocnemius contracts, opposite happens, right? So there is a tendency of falling backward. So we want a neutral position, right? So simultaneous contraction of both flexors and extensors. This is what we need. And how does this happen? Pressure receptors on the sole, right? Along with that, the skin and the muscles, the interossei group of muscles, from all of this, afferent impulses go to the spinal cord, causing a reflex contraction of both the agonist and antagonist. So, दोनों muscles अगर contract होंगी, only then the ankle will be in its neutral position, right? These things actually we don't realize it, but these things are operational when a child is starting to learn right, standing up straight, right, walking. So very, very important when these phases. These things are obvious in early years of our life when we start doing these movements. Okay. This picture must be familiar. We have discussed about this. So what happens when we talked about this when we discussed withdrawal reflex or flexor reflex. If you step on a painful, noxious or pointed or a sharp object, what happens? Same side may there is a flexion, right? But when you lift up your limb, it destabilizes the posture, right? So also what happens simultaneously is opposite side mein jo limb hai, there is extension on the opposite side, right? So this is also called as the crossed extensor reflex. Posture maintenance point of view say the crossed extensor reflex of the lower limbs is important, and specifically these things were studied in cats, right? So when a cat puts up a paw on a pointed object, there is a flexor withdrawal expected. This destabilizes the posture of the cat. As a response, what happens is there is a hyperextension of the opposite forelimb and the same side hind limb, right? So something like the crossed extensor reflex also was seen in animals, right? You do not need to write about the cat in your exams. If you are asked, you can directly quote about the flexor reflex, withdrawal reflex, and the crossed extensor reflex. Okay. Tonic, labyrinthine reflex, and neck reflex. The purpose of this reflex is to maintain a steady position of your head, and this reflexes become operational when the trunk is inclined. So there are a lot of conditions when the trunk of the body might get inclined. So I have listed some of them. When you are standing on an inclined plane, the trunk is inclined. So these reflexes come into picture. When a person is diving or is supposed to fall accidentally from height, again the position of the trunk has become inclined now. Whenever you are going for some type of sports activities, so you can see in this picture, there is an inclined position of the trunk. Here also the neck has got tilted to one side. So these are all situations where the tonic, neck and labyrinthine reflexes act. And how do they start acting? What is the mechanism of action? So vestibular receptors in the muscles, right? Vestibular receptor is there in the inner ear. Receptors which detect position. Muscle may and joints may in the back, in the neck. So joint may and muscles may the receptors which detect position. From all of these places, information is relayed to the brainstem, from where the brainstem is there processed, and accordingly, jaisa posture hai, it needs to be corrected. So accordingly, tone of the required group of muscles will either be increased or decreased. तो ये होगा कैसे? By modifying the activity in the vestibulospinal and reticulospinal tracts. So in all of the situations, this reflexes will somehow work to maintain a erect posture of the head. So there is redistribution of extensor tone in the limbs. If a person is standing straight, right, head erect, so the neck is neutral. There is nothing, no traction, flexion, extension, nothing on the neck. So if you put your head erect, the neck is neutral now. But the position of the vestibular apparatus, there is a slight difference now. Look at this picture. When you are standing straight, position of the horizontal semicircular canal, right, it is at a degree of 30 degrees from the horizontal actually. So tonic labyrinthine reflexes are activated, and because of this, extensor tone in the lower limbs is increased, and in the upper limbs the extensor tone is reduced. This is tonic labyrinthine reflex. The opposite scenario is where, suppose you have flexed the neck forward. So labyrinth mein now it is aligned to the horizontal. There is no problem with the inclination now. But now what has happened is the neck has flexed. So receptors in the neck, they become active now and they trigger the tonic neck reflex. So what happens again? Extensor tone in the lower limbs increases and in the upper limb it reduces. So you see, if you are standing straight or you flex your head, in both these situations, extensor tone specifically of the lower limbs is increased because of this. This helps you to maintain posture. तो दोनों situations में अलग-अलग mechanisms हैं, but the output is the same. Extensor tone in the lower limbs increased, upper limb it is reduced. In the first case, it is the tonic labyrinthine reflex. The second case, it is the tonic neck reflex. What happens when infant is crawling? Here again, we have a situation where the trunk is at a certain inclination, right? Erect posture पे नहीं है. So when an infant is crawling horizontally, so what will the infant always do? The infant will try to hold the head up. Now, in doing this posture, in attempting to extend the head so that the head, upright position of the head is maintained, there is extension of the neck. So now extension triggers the tonic labyrinthine, tonic neck reflex, because of which forelimb में tone increases, right? Ultimate idea is to maintain erect posture and support the head. So because of this, forelimb में the tone increases this time. In hind limbs, the tone reduces. So this happens in crawling position, right? During free fall, what happens? Again, so a very classical example of trunk not properly aligned and inclined. So upper limbs, so same scenario, whenever there is an accidental fall, so to prevent injury, the reflex posture is the head is extended. Now as the head is extended, by the same mechanism, upper limb tones will increase, extensor tone will increase, lower limbs are flexed. So this posture is so that there is no injury, reducing the chance of injury. This is the reason it is there, right? Now what happens, say a similar scenario when a person is diving, right? So do you see the similar, here also you find a loss of proper inclination of an accidental fall and dive is almost the same. Here you do not find this particular posture, right? So diver जैसे उसने सोचा है, he or she will dive accordingly, right? Have you ever seen a diver diving like this? No, everyone dives like this finally. So this just tells us that all of these postural reflexes can be suppressed voluntarily. This is the inference from this example. Rescue reaction. Rescue reaction is one more scenario. So when the foot comes in contact with any firm surface, the foot places itself on that. Any part of the foot coming in contact with a firm surface, the entire foot is placed, right, firmly on that surface, and this happens by adjusting muscles of the leg. Remember, leg में you have both the dorsiflexors and the plantar flexors. So दोनों को it will be adjusted accordingly so that the foot can be placed firmly. This reaction is also triggered during a fall, preparing the animal for landing by causing extension of the forelimbs, right? These reactions and reflexes were studied initially, discovered in animals, and as I say, in most cases experiments on cats. Now these rescue reactions, like this particular one, placing reaction, happens because of the stimulation of otolith organs by gravity. Now what is this otolith organ? You look at this picture. So this is a picture of the inner ear. Inner ear में these three structures that you see, these are the semicircular canals, right? And this part is the cochlea, concerned with hearing. Now, here you have something called a saccule, and here the utricle. These two structures are concerned with detecting linear acceleration. These are stimulated by gravity. How? Inside this, right? Inside each of this, there is a mucus patch where you have receptors like this. You will read about this again in special senses when you talk. But for now, you just remember you have some type of hair cells like this where you have cilia, and you can see normally from one end to the other end there is a progressive increase in the height of cilia. So whenever a smaller cilia bends towards a taller cilia, there is depolarization and signals in the particular nerve. Now how does it detect कि gravity में कहाँ से आए इसमें? So you talk that these reflexes are triggered by gravity. So this is because on top of this cilia there are crystals of calcium carbonate. These are called as statoconia or autoconia, and normally you will find they are uniformly distributed. If you are just standing erect, uniformly distributed. एक uniform bending है, so there is a resting rate of discharge in the nerves. Whenever there is a change of posture, so you can see what has happened on leaning forward, crystals have also moved forward. Now these crystals are moving under the influence of gravity. So that is how this whole receptor is responding to gravity, right? So there the bending will be affected, they will change, right? It will either increase or decrease. Similarly, if the person moves the head backward, the opposite thing will, bending will be in the opposite direction. So by this, the otolithic organs, utricle and saccule together are called as otolithic organs. They are responding to gravity, and hence they can detect when there is a fall. So utricle and saccule in our ear, they are oriented like this, right? These are the cilia, these are the crystals. So utricle responds to horizontal movement, saccule responds to vertical movement. Hopping reaction, what is that? So this happens when the body is suddenly pushed forward. So what is our usual response? If you get pushed from behind, we tend to lose balance, but that is rapidly corrected. How? Usually if you get a push from behind, we step forward. So this particular movement, what does it do? It shifts the disturbed center of gravity in between the legs again. So for us to maintain balance, the center of gravity should be in the line between the two legs. So whenever we get a push from behind, it is our instinct to the leg jumps or hops in the direction of the displacement so that the center of gravity is again brought between the legs. So this is called as hopping reaction, right? Last of the reflexes is writing reflex. So purpose of writing reflex is again when the body goes off balance, right? The writing reflex helps us to regain the upright position. Receptors for this again is in the vestibular apparatus, neck stretch receptors and mechanoreceptors of the body surface. So if you have observed this, any way you throw a cat, it will always land like this, right? So all these writing reflexes are so much functional in a cat that in mid-air it corrects its posture. So if you throw a cat like this, first what happens is the neck or the head corrects. The head actually corrects. So this is the head writing reflex. When the head is not upright, right? Head position में थोड़ा सा भी change हो, the vestibular apparatus that we just discussed, they will somehow detect it and trigger correction. It reflexly activates appropriate muscles to bring the head back to upright position, right? So head righting reflex is this. Now suppose the body is lying flat. A person is fallen and one surface. So if you fall flat, either you will be supine or you will be prone. If you are supine, the posterior surface of your body is in contact with the ground, right? The anterior surface is not. तो ये जो differential pattern है, accordingly the head is reflexly brought back to the upright position either by flexion or extension. So if you are falling like this on your back, so the correction will be by neck flexion, and if you are falling like this, the correction will be by neck extension. So idea is always to maintain upright position. First the head will be taken care of, followed by the upright position of the body. So this is called as body on head righting reflex. The last of the righting reflex is righting of the head while the body is still horizontal. Right? So head has been corrected, but the body is still horizontally placed, either supine or prone. So appropriate muscle groups, flexors or extensors will be activated, by which eventually the body regains its upright posture. Neck on body righting reflex. Right? If you observe a child in infancy, you can observe all this type of reflexes as the child learns to sit straight. You will find that the child crawls to one side and then starts sitting straight. So observe, if you have an infant in your family, you can actually observe all of these things, right? This reflexes and details you will again learn when pediatrics is taken care of. Lot of these reflexes you will have to clinically examine, right? So we'll stop here today. So what are the different postural reflexes if you are asked? You start with tone of the anti-gravity muscles, followed by positive supporting reaction, then crossed extensor reflex, tonic neck and labyrinthine reflexes, rescue reactions where we discuss two, placing and hopping reaction, and righting reflexes at the end. The purpose of all of this is, remember, to maintain somehow erect posture, right, and to avoid situations where there is a destabilization of posture. All right. So all levels, for spinal cord se leke cortex tak, you have different levels of protection, which is protective reflexes which are there. Fine. All right. Thank you.